Rachna Jaju, and our expert is Dr. Madhulika Agarwal, ma'am. Can we have the series, please, Abhishek? Dr. Manish Pandey, sir, is a professor and head of the department uh, at Mahavir Hospital and Manish IIT Center, Sai Baba Ultrasound Center. He has many special awards and achievements, including the Dynamic Indian of the Millennium by KG Foundation, the Gynec Excellence Award by Foxy in 2020, a commendable editor-in-chief by ESHRF in 2021, the Icons of Gynecology in World in 2024. We welcome you, sir. The list of awards is never ending. Our next moderator is Dr. Rachna Jaju. She is currently the chairperson of the MTP and Family Welfare Committee of the Maharashtra Association of OBGYN. She is a part of the Mission Think Health Committee Maharashtra State, MTP Committee Foxy, the Secretary MKH Latur, the past Secretary of Latur OBGYN Society, and she has received prestigious Spurti Award at a MOX. She has been the past Secretary of IND Women's Doctor Wing at the Latur branch also. We welcome you, Dr. Rachna. Our expert for today's panel is Dr. Madhulika Agarwal, madam. She is the president of the Jaipur Menopause Society. She is also being the secretary of the same, the vice president of the Jaipur OBGYN Society of the year 2022-23. She has presented various papers in national and international conferences, and her key interests include ultrasound and high-risk pregnancy. We welcome you, ma'am, as an expert for the panel discussion. Today, we have many invited panelists with us who will be discussing an important topic of contraception. Our first panelist includes Dr. Monica Gupta, madam. She is also the convener of this program and the Western coordinator of Fox Public Awareness Committee. She is the HOD and senior consultant at Dux Hospital, Alwar. She is a hysteroscopic and laparoscopic surgeon. She has been the president of the Alwar OBGYN Society and the Foxy. She has received the Foxy Achiever Awards, the Feldstone, Newark Foxy at Ranthambore. She is a Dira Master Trainer and the Manyata Assessor. We welcome you, ma'am, as a panelist for this panel discussion. Our next panelist, Dr. Sejal Naik, is the National Coordinator of the Endoscopy Committee, Foxy. She runs the Foxy IIT Recognized Training Center for Gynec Endoscopy. She also has a Foxy Young Achiever Award in 2018. She has also received the Best Paper Award at the AICOG 2019, the SOGA Star Award of 2018 to 24. She has been the organizing chairperson of UVA IIG 2019 as well as the EVE IIG 2022. She has been the honorary secretary of Surat OBGYN Society, and she currently is an endoscopy and infertility specialist at MTP Women's Care Surat. We welcome you, ma'am. Our next panelist is Dr. Megha Shastri, madam. She is a senior consultant at British Hospital, Surya Hospital, and the Kapur Hospital, Jaipur. She is a member of the Foxy Medical Legal Committee, the ex-member of Foxy Public Awareness Committee. She has been a Manya assessor and trainer. She is also the RSC module trainer and the HPV vaccine champion. And the ex-lecturer at Rajendra Hospital, Mumbai. We welcome you, ma'am.
Thank you, ma'am.
Our next panelist is Dr. Sanju Agarwal. She is from RNG Medical College, Udaipur. She has done her BGO from Madurai Medical College. She is a consultant at Sanya Hospital, Alwar. We welcome you, Dr. Sanju. Dr. Zalab Shah is working at Rachna Women's Hospital, Patan. And she has passed her MD from Vadodara University with a gold medal. She is interested in incorporating high-risk aesthetics and improving women's health through preventive and postpartum care. She is currently the working secretary of Patan OBGYN Society. We welcome you, Dr. Zala. Our next panelist is Dr. Prema Nagar, madam. She is a laparoscopy surgeon and an infertility specialist, a director and consultant mom and women hospital. She is also affiliated to Sarva Hospital at Vadodara, Gujarat. She has worked as a senior resident and as a consultant in various hospitals. Her special interests include holistic approach in women's health, endoscopic surgery, cosmetic gynecology, and women's health and the fitness influencer. We welcome you, Dr. Prema. Our next panelist is Dr. Pragna Harshi, madam. She is a director of Harshi Hospital at Jabalpur. She is a consultant also at Sutika Hospital, an executive member of the Jabalpur Menopause Society and president of the Jabalpur OBGYN Society currently. She has held various posts in the Jabalpur OBGYN Society. She was also the treasurer of Foxy West Zone Conference in 2022 and she holds special interest in high-risk pregnancy and gynecological surgeries. We welcome you, ma'am. Our next panelist is Dr. Prajakta Gurude. She is the director of Mahir Hospital and Nucleus Test Tube Baby Center at Pune. Her special interests include infertility. She's been practicing since last 12 years. She is currently the secretary of Ogier OBGYN Society as well as the Ogier Doctors Association of Women's Wing. She is a member of AMOX Public Awareness Committee and the Sexual Health Committee. She is an organizing secretary of the upcoming AMOX Zonal Conference. We welcome you, Dr. Prajakta. Our next panelist is Dr. Sujata Kulkarni Madam. She is a consultant obstetrician and gynecologist practicing in Solapur. She is currently the vice president of Solapur OBGYN Society, and she has held various posts in Solapur OBGYN Society. Her areas of interest include female infertility, adolescent health, and public awareness. She has also been the recipient of the first Dr. Meera Today Gold Medal Award. We welcome you, ma'am. I request the moderator to please take over for the panel discussion.
Thank you, Monica madam. Thank you for giving me whole cricket team, because there are 10 panelists and 2 moderators. Can you see my screen? Hello?
Yes, sir.
And
yes,
my voice is audible?
Yes,
I can see that my all 10 batsmen are there. So we would like to play good T20 over here. This is my credentials. Thank you for kind words, madam. The moment child is born, mother is also born. Today is World's Population Day, so we have to salute all the mothers who had given us birth and make this world more populated. 3 books written by us is recommended in Royal College as a reading material. Atlas of Pitolicography and Technique of IVF made easy, again for 2nd edition. I am editor-in-chief of 2 journals, Indian Journal of Obstetrics and Gynecology and Open Access. Last year at Copenhagen, I got opportunity to interview Professor Herman Turne, and that all you can see on this Manish YouTube channel. I welcome all my panelists. Dr. Rachina Jaju is there? Dr. Yes, yes. So welcome as a moderator, and we must thank Dr. Madhulika madam to be our expert. I'm just making this window small. Just 1 second. Okay, let it be there. So today we are discussing this. Ashish has told Jimmedari Nibhao, Plan Banao. Okay, so for that I must thank my teacher Nitaben Yagnik, who has given me very good thing. Those who are from Civil Hospital Ahmedabad, out of my all panelists, what you understand by GATHER, gather approach. GATHER. Those who had learned in medical college, they must know. Sejal madam, you are gathering so many people, so many webinars. Before 3 days we are in webinars. We are gathering all the people. You must know what is gather approach. Gather approach is the ultimate approach in contraception. First, we have to greet her, ask her why Sejal madam has came to me, teach her which are the different contraceptive models available, just like Ashish sir has told, help her to choose whatsoever she has chosen. We have to explain in detail, and most important thing in any counseling is recall. So greet her, welcome, ask her, teach her, help her, explain in detail, and recall. This should be the motto of contraception, so people can use contraception rather than saying copper is best for you, condom is best for you, implant is best for you, lark is best for you. No. Give them the choice, and we must know. And I must welcome my MTP committee chairperson of EMOGS, Dr. Jaju. So we will start with MTP. First question, what are the investigation would you like to go before MTP? Monica, Sejal, Megha, Sanju, Jalak, Prema, Pradnya, Prajakta and Sujata. Because I see, sir, what are the investigations? Because MTP is coming regularly. And I see that people are taking MTP just like Chana Mamra. Patient is coming, you are doing MTP and patient is gone. Am I right?
Absolutely. Nobody does like that.
Nobody does like this, madam. What you do? Suppose.
Sir, we first of all we do transvaginal sonography.
So first we will take history.
No,
So first we'll take history.
of course.
Medical history.
Sejal, can you give me the definition of history?
So you ask for investigation, so that's I.
Okay, which are okay investigation? Chalo. Okay, ultrasound. Then you go for blood test. You go for urine test. If you this time I must thank AI and my resident Kishan and Vaishvi. First time they had made this presentation with Chat GPT. So you can see so many things repetition. But AI can give you very good presentation. Then this is the one of the example. This presentation is totally made by AI and બીજું શું છે Giga. Gamma. This is the Gamma. So these are the two things by which you can make your PowerPoint presentation wonderful, and they will give you everything. Okay, so yes, madam.
Ahead of techno.
Yes, sir. Just Gamma we had used just installed yesterday, and we had used in this presentation. And with Chat GPT, this presentation is made. So, madam, you rightly said ultrasound. With ultrasound, you would like to see for gestational age, okay? Pregnancy location, whether it is centrally, eccentrically, or cornual. You can see any abnormality in the uterus. Okay, then any blood test.
So we go for routine CBC to see the whether anemia is there.
Yes, very good.
Then RH
Okay,
blood group and RH factor. Then coagulation profile for the patient.
okay,
And then we have biomarkers for HIV, HPLAG, HCV, BBRL.
very good,
So
very
these-
good.
So these are first basic.
Basic investigation, basic investigation.
Yes.
Sometimes we may see for urine for infection.
Routine.
Anybody would like to go for this test?
No, sir.
This is Chat
Whenever in
GPT.
doubt, we should.
This is Chat GPT, but routinely we are not doing in India.
We can take the opportunity to tell the patient that yes, these are the screening tests ideally you should undergo.
Yes, madam. Yes, madam. Then, how you prepare your patient for MTP?
The counseling, if we are giving medical method of treatment, then the counseling part is the most important. Otherwise also, that how to take the tablets.
Okay.
So
And
first we'll make her understand what are the pros and cons of whatever method we are going to use on her.
Yes. Again the gather approach.
Yes. Because first we have to make her understand what we are doing.
Yeah.
And then accordingly we have to take a consent for her, because to her to understand and then sign the consent is the main thing.
So
And then
in-
accordingly we can go for whatever the gestational age is. Accordingly that we can go for whether we want medical or we want surgical treatment for her.
So you are preparing only patient for MTP or post MTP?
Manish sir,
Yes, sir. Yes, madam.
sir, sorry to interrupt, Archana. You should give the definition of history. That is extremely important in your words.
History is study of past in light of presence to have good future.
wow.
Very nice.
This is the definition of history. Every day we are asking history. We are asking history in present. Patient is narrating in past, and we have to give good future. So if patient is coming from MTP, we will advise them to go for second MTP. So in counseling, we must include contraception. We must include contraception. And we also see, we have to also see that this MTP is legal and ethical, because so many times patients are coming with husband who is not husband, just a boyfriend. So how you can confirm whether they are married or not? Big question and big fallacy, day in day.
So
We don't
we
need
ask
the
for the
husband to come.
husband and wife.
No. If suppose she is unmarried,
Only the wife and person consent is important. We are not supposed to take the consent of the husband only if the patient want to whether married or unmarried. If she wants an MTP, we have to give the services, but we can explain what are the pros and cons for everything.
If the patient is major, we can take.
yes, I must say you must see the age. If she is 16 years,
Yes.
then you are liable for POSCO. You have to inform the police. Huh? And then, so we always have to think that the looking lady may be 20 but she may be 17, and we done MTP, then afterwards some police will come and then will narrate you. So always word of caution should be there. Whenever she comes, don't be too much generous to her and give them the service. We have to think of ourselves also, because recently we have got so many cases of POSCO running in our gynec doctors.
Yes, sir. When we are doing usually as per Aadhaar card. We are taking the Aadhaar card for of that
Yes.
person. In the Aadhaar card, whatever the age is written, we take it as such.
Yes, ma'am. Yes.
Whatever
So-
there is in the Aadhaar card.
So always,
But
always.
according to the new law, it is not the Aadhaar card, but the school leaving certificate or the birth certificate of the patient that has to be kept as a record. They usually don't carry
That
that.
is very difficult to get a birth record of that.
School leaving certificate is right.
But one thing I will tell, MTP is not an emergency. If she may go to some another place, let her go. But always be safe on your side to prove her age, because nowadays patients are making you fool. We are on a general side. बेचारी को बच्चा रह गया, हम गिरा देते हैं. Then we are in a soup. Once you have done the things, you are the culprit. Because MTP committee, Jaju madam says, well, how much law are strict in MTP committee. Okay, so emotional support we should always give, but we have to take care very much for our patients, and follow-up should be there. So in conclusion, we have to give very much comprehensive approach. We have to go for termination, and pre-procedural care too much we have to take, history taking, medical examination, physical examination, confirm the pregnancy, do all the tests, see for the gestational age, discuss with the patient, and always discuss contraception. Patient counseling, medical evaluation, confirmation of the pregnancy, prepare for future. Now, Rachana madam, this is your turn.
Yes, sir.
Yeah.
So now there is a patient having 9 weeks of pregnancy. She is gravida 6, para 3, living 3 with 2 abortions, and she comes with an HB of 6 gram. And she requested for medical termination of pregnancy, that is MTP. Now, how will you go about this case? So I think we'll go with Dr. Monica Gupta, madam. How will you evaluate and proceed further?
As the patient hemoglobin is very less.
6 gram
So
madam.
first we have to find out what is the cause for less hemoglobin.
Okay.
As the patient has come for the MTP, we have to counsel if you might have a bleeding for 10 to 15 days. So your hemoglobin will fall. If you want to have an medical termination only, then you have to go for the correction of anemia before going for it. It's better you should go for a surgical intervention, because we have to tell them what is good for the patient or not.
Correction of anemia. First thing
Madam,
is
this
correction of
MTP is not an emergency. If
Yeah,
suppose
to
she
find out
will
what
wait
is
for
the
1
cause of
week,
anemia and then correct it.
so first stabilize the anemia. It's as such it is a 6 gram. Minimum we will require, Jaju madam, is 10. Okay,
Yeah.
minimum. Because if something untoward happened and we had done MTP, then we are in soup.
So we need 4 units of blood.
Yes.
So we can wait for 1 week. We can give an injectable iron to the person, and then we can proceed for the MTP.
So what would you prefer, a blood transfusion, that is PCV, or iron transfusion, intravenous iron?
We can give for intravenous iron also. And what is the patient choice basically? If she can wait for 1 or 2 weeks, we can give her intravenous iron, because the result of FCM are very good. But if she is in the emergency, she wants it right now, we can go for the blood transfusion. But we have to explain what are the problems with everything, what are the benefits, and what are the problems, what are the complications they are going to happen because of both the procedure.
Madam, according to patient has got emergency, so we have to do it hurriedly.
Yeah, it is a 6 gram hemoglobin. It will require more time to improve to till 10. So preferably we'll give at least transfusion first, and then IV iron for maintenance, and followed by oral iron for the long time.
Very true, ma'am. Very true. And what investigations would you like to do for such patients?
Yeah,
Such as
they- So, madam, reason for her low hemoglobin, we have to find it out. Whether she is not taking good diet, or whether her absorption is not good, or whether she is bleeding, having a rectal bleeding or something like that. Or she may be menorrhagic previously before conception. So, then the iron profile we can do. Total iron binding capacity and the serum iron, etc. And B12 deficiency is also common in India, being majority are the vegetarian. So these all other rules, reasons.
any role of HB electrophoresis over here?
Yes.
Yes.
That is usually what happens, madam, when the hemoglobin is very low, then the HB electrophoresis reports are really very dicey. So iron profile first, followed by correction of iron, and then if we go for the HB electrophoresis, once the patient is settled down, that can find out a reason for her low hemoglobin.
And Sajal madam, we can ask for interval MTP because those patients are coming with 6 gram of hemoglobin. We must ask that how long before you had gone for previous MTP. Just like interval delivery, we now think have to interval MTP also. Because we don't know how frequently she has gone for MTP. So if she are just like one by one delivery, she can have a one by one MTP also. So we must ask what is the last MTP she has undergone. Why her HB is 6 gram? Iron deficiency may be the cause, but frequent MTP can also cause her 6 gram of hemoglobin.
Yes, sir. In this case, she already had 3 live deliveries and 2 abortions.
Yeah,
So technically, this is the 6th pregnancy.
6th pregnancy. So that's why I am telling na.
Yeah.
Okay, you have to see the interval MTP distance.
Yes, sir.
Now, if there is thalassemia minor trait, then even if you are giving her blood transfusion repeatedly, her HB will not be rising. So there comes the role of HB electrophoresis to rule out if she is having some traits of that sort.
Madam, in this particular case, we might not think about this because she has already undergone 3 deliveries. But in routine, we can go for because already she has got 3 live child, no thalassemia. So this might be the cause of frequent MTPs because according to madam, this is her 6th pregnancy. Yes, madam.
So how will you counsel the patient? Dr. Megha Shastri.
Ma'am, cause like how sir said, it's a complete gather treatment has to be done here. For counseling also, we have to counsel in the same way that, she should not go first thing with the repeated abortions and repeated pregnancies. That should be the first thing. And whenever we are counseling, we should make sure that we counsel her about the contraception also. Because we cannot keep having her coming to the hospital, getting pregnant, putting blood or putting IV iron. So main in counseling was everything, sir, including the timing because there is no emergency. So we can always hospitalize her, stabilize her, and then we can go ahead. So first we have to counsel her for the admission, then for the blood transfusion, and then the method and contraception.
So we have to counsel her that she has to wait for some time before going for MTP.
Yes, madam, she has got 9 weeks of pregnancy. How everybody will proceed in this particular case?
Dr. Sanju Agrawal, madam. Has madam joined?
Dr. Jalak from Patan. Dr. Prema, Dr. Pradnya, Dr. Prajakta.
I would like to do it that way that I prepare 2 PCVs, I will transfer 2 PCVs, then we do the MTP. And
That is a surgical MTP. That is a surgical
yes,
MTP.
surgical MTP, and then we put the patient on either IV iron or oral iron.
Okay. Anybody will disagree? Dr. Megha Shastri, Dr. Sujata.
Sir, I would like to, once our hemoglobin is built up,
Okay.
it's better we give 1 single tablet of mifepristone.
Okay, now HB is 10. Dr. Jaju madam and Sejal madam has given her blood transfusion. That is good, very good PCVs. Now her HB is 10. Then?
Medical termination, actually we can try in hospital. I mean, what we will do is we will give her mifepristone, we will wait for 1 day. Then misoprostol we can give on morning. Let's see after 4 o'clock if she aborts, then we can just do a suction and just do a checkup, check curettage.
Just uterine aspiration you can do if suppose some product or reproduct of conception remain.
Yes. So we can do a combination of medical and surgical.
Thank you very much. Jaju madam, second case.
Just a second. A gravida 3 para 2 living 2 with history of previous LSCs. She has preeclampsia, hypertension and diabetes. So how will you go about this case? I think we'll go with Dr. Prajakta this time. She is 8 weeks pregnant and
This is the case of third gravida with previous to LSCS. So we would like to have the history first, and since she's having 2 cesarean sections and she's 8 weeks, so we would like to go with her surgical termination, but probably we should counsel her regarding the pros and cons for it because she's a case of previous LSCS. There may be chances of injury, so we may explain the patient, and then we will generally we will do her examination, and we would like to have her investigations done priorly. As mentioned earlier, we'll do her hemoglobin status and everything. If all the things are in routine. So I would like to do her surgical termination rather than going for medical.
Madam, she is diabetic, so
hypertension and
diabetes both.
Okay. Yeah. Then we would like to assess her status for diabetes. I'll do her HbA1c priorly to assess her status and whether she's on any oral medication or any insulin she's there. So we will control her blood sugar levels priorly. And she's in case of hypertension, we will evaluate her status and before doing this.
So again, there is no need of
for
emergency.
hypertension,
We should
there
control
will be
her medical
chances.
disease first, and then we will go for termination of pregnancy. As such, you have told previous 2 cesarean section, so you can go for surgical or medical method. Okay. Which method would you like, surgical or medical?
So she's diabetic and hypertension, so there may be some liver derangement or renal derangement may be possible. So we may go for surgical, will be the better option rather than medical termination in this case.
Dr. Sujata?
Madam, sir, we would like to go for a medical termination. The planned, we can give mifepristone on day 1 and then day 2 or day 3 we can give 800 milligrams of misoprostol. And if she does not abort it in the evening, then we can do just a suction fluid. Because she's already previous 2 scar with diabetes, with hypertension, she's the high risk patient.
Everybody agrees? Because there are 2 things with mifepristone, antiprogesterone, second misoprostol making uterus very contract. So chances of perforation will be very less. And second thing, misoprostol will also dilate the cervix. You have given there at 12 hours time. So suction evacuation after doing this is very safe in our hand. And as such, she is diabetic, hypertension. We already control her diabetes and hypertension. So after controlling this, we have to do this medical termination of pregnancy with medicine plus added needed surgically. Taju madam, your inputs?
So rightly said, we will have to make the cervix right because it is a previous to LSCS. We are likely to encounter a tight hose. So after giving medical treatment, if we go for surgical evacuation, that will be more easier for her. Second thing to be considered here is if she is having say diabetes or hypertension and she is not a person for medical abortion, the drugs may be hepatotoxic for her, then we can also think for surgical evacuation for such patients.
Otherwise, it's okay.
Otherwise, it's okay.
We have to give a prophylactic antibiotic to the patient because chances of infection in the diabetic patients are high.
So we will give one additional prophylaxis, but now she has got previous 2 CS, both the babies are live. These are the basket of contraception. So how you advise?
So she's
Non-hormonal or procedure.
So first we have to ask about the sexual history. How many times in the month she makes the contact.
Okay.
Whether she is doing the contact only once in a month or many times the husband is living outside, so we will
Then condom is good.
and what is the need and what is the choice of the patient.
Okay.
Then we have to give our opinion. If this will be better for you or which is better for us. We should not guide the patient कि आप property लगवा ले या you go for the injection and all. In the last we can say कि this is better for you. In my opinion, I recommend this and what is your choice, you can have it.
So again we will give them the basket.
I think she requires a long-acting one or the longer duration, like have the protection.
Madam,
So, maybe the-
Sejal madam, she has got already 2 kids. Both kids are healthy. It is almost of 7 years and 9 years. Then
So for if she asks me, my recommendation for her is to long-acting devices, intrauterine.
but now she doesn't want any kids. Why this MTPC fed up? I have got diabetes, I have got hypertension. My husband is not listening. I am becoming pregnant and again, and then I have to go for MTP. Then it will serve 2 purpose. This will serve 2 purpose. You can do surgical MTP. You can see by laparoscopy. Tubal ligation is nowadays safe. So it will serve our purpose also. We are not perforating and we are doing the best thing. So with her medical condition, I think permanent contraception for this lady is advisable. Everybody agrees?
Yes.
Sir, in the previous 2 cesarean, doing a laparoscopic sterilization is little bit difficult. It should be done only in the center. The person is very expert in doing it. You never know what you see in the abdomen.
Madam,
You can advise the vasectomy for the men.
yes,
You have to go for
that is the best option.
instead of the female. because the complications are less for the male than female in this case.
Madam, if we are in the era of Sanjay Gandhi, then it will be very easy to do the Nasbandi. But nowadays to counsel a male is very difficult. And madam, let me tell one thing, that previous 2 cesarean, previous 3 cesarean or previous 5 cesarean, laparoscopy tubal ligation is much more easier than the open tubal ligation. Sejal, would you agree?
Sir, but in rural settings, we have to like.
Okay,
see
but
a-
there should be done by expert. There should be done by expert, but more cesarean section, the laparoscopy will be very easy, madam.
So I would like to add one thing.
During
The era
when we are
when
talking about the property,
you
you
have to
Huh?
can counsel
counsel
her.
the
I
male
would like
part
to
of
say one thing, if
everything.
we are going for the medical.
Now our panel is looking very good. Everybody is speaking, so we are happy. Jaju madam, we are happy that our panel is going very well.
Say one thing, if we are going for the medical termination,
Okay.
then long intake intrauterine device is going to be a better option for her, which will work for 10 years.
Yes.
So LNG IUD, LNG IUD.
Fertile window, anyway, we cover the fertile window.
If we are going for medical, then
Before MTP, we can counsel her. Before MTP, we can counsel her that
Yes.
if we do operative, at the same time we can put an LNG IUS or multi-load for you. And if you have an ultrasound, if you're fortunate enough to have an ultrasound in operation theatre, we can be very well confirm that yes, we have done the MTP very nicely and the device is also fixed.
So ultrasound guided MTP.
Yeah.
Ultrasound guided MTP.
Yes.
Madam, in how many centers can you do an ultrasound guided MTP?
That is it.
But when we
If you're
speak in the-
fortunate enough, then only we can do.
Only madam, hardly 1 or 2 centers are doing it. Everybody is doing a blind MTP.
And even though there is no complication till date. Otherwise MOGS MTP committee member will come and give us liable for this. Okay, Jaju madam. So we are doing MTP, and MTP is bread and butter for so many things, and MTP is coming every day. Sarkar, that's why making MTP कायदेसर खानगी and सलामत. It is safe, and now it is जिम्मेदारी निभाओ, प्लान बनाओ. लेकिन 20 के पहले बहुत सारी प्रेग्नेंट हो जाती है, तो we have to advise them not to become pregnant. That is our motto. So as rightly said, we can go for IUD, that is copper or hormonal. We can go for implant, which is very effective. And Ashish has rightly told that if somebody wants to learn, we can come and take advice from him, and we can get government free implants. We can also go for depot. It is also 3 monthly injections. We can give them progesterone only pills because patient has got hypertension and diabetes. But only disadvantage of POP is that should be taken at proper time, otherwise there will be loss of his action. Okay madam, every day at the night at 10 o'clock she should take the progesterone only pills, and we can also use centromin for these patients. As madam has rightly said, his husband is working in a field and not coming regularly at home. We can give them the advantage of male condoms. Permanent method, rightly said, if it is good, patient agrees, then we can do with either open or laparoscopic tubal ligation. Other consideration, we can't give COCs because patient has got hypertension and diabetes both. Another case, madam, with CHD. Jaju madam. Yes, madam.
Sir,
Yes.
I want to add one point.
Yes.
Sir, we have all the time we should explain the patient about the complications also.
Yeah.
When we are giving a DMPA injection, we should tell that you can have a irregular bleeding.
Irregular
you can have
periods,
menstrual
intermenstrual bleeding,
because most of
sometimes
the time
amenorrhea.
when the patient is taking POPs or whatever the things are there, we don't tell. And all the time she knows that ek goli leni, and what happens if she misses the tablet? Or even though if she is taking regularly, she can have a irregular bleeding in between. So these all things we should explain. We should have some time for her to explain the complication and effects of the side effects of the drugs also.
That's why in Gather, explain in detail. You have to tell 1 or 2 things more, because this contraception is for 3 months, this contraception is for 5 months, this is for 5 years. Explain them in detail. And second most important thing is, madam, recall. मैंने क्या बोला, मेरे को फिर के सुना. Then she should not say that you had not explained to me this. Whenever DMPA given, we say that you may become amenorrheic for 3 months. There might be intermenstrual bleeding. There might be postcoital bleeding. Okay, and sometimes you feel like pregnancy-like situation. Okay, Jaju madam, another case.
a 20-year-old primate with 10 weeks of gestation. She has history of dyspnea on exertion, and she has occasional epistaxis and hemoptysis for last 5 years. Her ECG, her echocardiography shows a non-restrictive perimembranous VSD and a balanced shunt and a significant pulmonary artery hypertension. Should we advise her MTP? Anyone who would like to take that question?
Now difficulty will increase. Case by case.
First thing is, we can't advise the MTP. If she wants the child, so it's her choice to have an MTP or not.
Madam, she is primary with VSD and PH.
Yeah.
So would you advise him that she should continue the pregnancy? Here not MTP. We are advising them whether she should continue this pregnancy or not. If she continues, what are the risks? If she terminate, what are the risks?
Risk. And sir, in this case, we have to see both. We have to see the maternal risk as well as the fetal risk.
Yes.
Already having a long history, 20 years old, what are the risks to the mother would be on the higher side. So we have to explain to her that because of the pregnancy, she can have heart failure, arrhythmias, maternal mortality will be on a higher side. So it has to be an informed choice to her. So what are the pros and cons of both? Whether she should continue or she should not. So ideally, termination would be in favor of mother would be a good option available to her. But then again, it has to be her choice.
Her choice, and we have to also see for the baby also.
We shall involve the cardiologist.
Yes, madam. But patient came to you, Sejal madam. She is primary. She had not explained this thing to her maternal side. Husband is not knowing that she has got VSD, she has got PH, and they got married. Now she became pregnant. When she was non-pregnant, when she had came in adolescence, we had advised them to correct this congenital heart disease, then got for marriage. But now she got married. Within a 6 months, she became pregnant, and now she is coming to you because you had already seen her. Okay, so you know the case. They won't go to some another place. They will come to you only, and you are in a soup because she has got cardiac disease with pulmonary hypertension, VSD. So what we will involve everybody, but what is best for her that we have to decide. So there should be multidisciplinary approach. So we have to take cardiology consultation.
Should detail counseling regarding the risk involved for the maternal health in this case.
And maybe also because of the poor.
Fetal medicine people also, because in her case even the fetus is at risk. So we have to involve both. For the mother also we need a cardiologist. For the fetal also we need a fetal-maternal.
Because baby will be IUGR. Because of the poor cardiac compliance, there will be less blood supply. There will be hypoplacentosis.
Exactly. So we have to tell her both that apart from her, even the fetus has these problems. So then we can ask her to take a call.
Okay, now we go send her to cardiologist. Now cardiologist says that your pregnancy is at risk. Now you have to go for medical termination of pregnancy. Okay. Now after 1 week, husband and wife both are came to you. Now, madam, mera MTP kar do. Pragya madam.
As soon as possible. Take the earlier the best. Yeah.
Earlier the best.
To as soon as possible.
In the tertiary care center we have to do.
Yes.
Tertiary care.
We have to take a cardiologist opinion also. Fitness, cardiological is basically fitness for the MTP.
We should do in a high risk center where all the
ICU and CCU are there.
Then for future pregnancy, now you all are expert. All my 10 batsmen or batswoman, because this is female cricket team. I am the only male as a umpire because we have got all females in my team. So you have done very good things to her. She because all 10 are female. Okay.
So first should be the correction of
Yes.
marriage issues.
Yes.
She need to have a contraception at least for coming 3 to 4 years till she stabilizes.
She is ready for pregnancy with least complication. So here she is primary. She has undergone MTP. Now which contraception?
Because if she is 20, so she can still wait to conceive again.
Yeah, she can wait.
So in her case, we have to advise if she goes for oral medication, then prostagen only pills has to be given. Because with COCs, there are chances of thromboembolism, and she's already a heart patient. So in that case, everything which is based on implants, injections, and pills, but it has to be progesterone pills. Only methods. Barrier methods are better, I think so. We can advise for the proper use of the barrier methods.
If they stick to
I
it,
think the injections also.
Now husband.
And Marinas, LNGs.
Yeah,
So,
Sir, LNG would be a
Better choice, yes.
Madam, with allergy, the periods will be decreased and she will have amenorrhea after 6 to 1 month, 1 year. 6 months to 1 year. She will be highly worried for that.
With proper counseling, we can get
Yes, sir.
I don't think it's a good choice for her.
and with the proper counseling, she can continue wearing the LNG IUD for at least 2-3 years. And there is a least failure rate with the LNG IUD.
Madam, she is very poor. She doesn't afford IUD, Marina. She says Marina. She says Marina.
They strictly adhere to the barrier contraceptive method, that is the best. If they strictly adhere to it,
Madam, they will strictly adhere because husband knows that her wife is MD. You know her wife is MD, manufacturing defect. If he does something another mistake, then he will be in the soup. Yeah.
Everyone has some defect.
So now it is a big defect, na VSD with PAH. So now he will be very much secure that even I don't touch her. If I touch, I have to touch with barrier contraception. There should be barrier between me and her. Okay, so we have to take proper counseling. Where my second moderator, madam, Jaju madam.
Yes, sir.
Yes, yes, मैडम आप चुप मत जाओ So now you can explain what we should go for this type of patients, madam.
So I have to say that no, she has to undergo a multidisciplinary approach as rightly said by Apri. It has to be a combined decision of all. We have to give her all the choices of how things will be. If she continues the pregnancy, if she terminates the pregnancy. If she terminates the pregnancy, then she has to use a contraception. She has to correct her heart disease, and then she should plan for pregnancy. And the choice of contraception is rightly said by everyone. Progestin only pills or LNG IUS or barrier contraception, whatever she prefers. And she can again plan pregnancy after that.
After correction of her heart
The
disease.
big no for UCI pills in this case.
Big no. Because in this type of patients, we can have more chances of thromboembolism. Okay, so recommended contraception, everybody exists, progesterone only. You see, ChatGPT also giving the same things. This is all ChatGPT.
now ChatGPT will be the future doctors.
No, madam, they are giving very good things. So we have to take the use of technology in our advantage. Gamma. This all the gamma effect. So permanent method is not good for her because she want to continue the pregnancy. Avoiding hormonal contraceptive pill because of the estrogen high risk. Considering choosing method whatsoever she choose, she should adhere on that method. So safest option we have to give to don't have thromboembolism, and we have to inform them. So medical termination of pregnancy and contraception. Again, this is another case, madam. 7 weeks of pregnancy, normal delivery 1.5 years ago, but now patient has got asthma and patient is using pump. Okay. Again, we have to take history. Which type of pump she is using? Only steroid pump or only Lotaheller, only bronchodilator? Everybody agree that we have to control the asthma first and then we have to go for termination?
Yes, sir.
We can do simultaneously.
Yeah.
We can do both the things simultaneously. We can.
How many of you have got nebulizer in your hospital or OT room? Because in this type of situation, you must require nebulizer. Or if you don't have, ask from your friends and then go for this MTP. Otherwise, anesthetist say there is no nebulizer. And madam, there will be very severe bronchoconstriction. Even with full IPPV, we are not able to dilate that patient because patient is using pump permanently and daily. So this all lungs alveoli are steroid dependent. So we have to very much secure that we should do justice to this our patient. So we have to go for proper counseling. We have to take informed consent. Administer again, we can, because it is a 6-week pregnancy, everybody agrees that we can go for mifepristone and misoprostol.
Medical termination.
Only thing in this type of patient we can't give, that is prostodine.
Prostodine. Right.
Prostodine injection should be avoided when patient has got asthma because we have to be secure that whenever there is respiratory complication or patient has got respiratory disease, don't use prostolin. Otherwise, whenever there is severe bleeding, somebody try to use prostolin, and that will again cause vasoconstriction or bronchoconstriction, and we are in a soup. Now, what is your advice? Because we are talking about the contraception. What is your advice for her as a contraceptive method?
So same
Long-acting
method.
device, maybe hormonal, non-hormonal.
PUPs only, because estrogen is contraindicated, so you can
Yes.
use progesterone pills, you can use IUDs, either non-hormonal like copper or LNG, IUS, and the barrier method still is a good choice, but you should avoid combined hormonal contraception with caution. PUP is the better, and if she opts for
She has got delivery only after 1.5 years, one child, only one child she has got.
We have to use a permanent temporary method for her. Permanent method are not suitable for her.
Jaju madam, any advice for asthma patient for contraception? Your
But if
MTP?
she's planning for a second child, then she will have to go for progestin only pills or IUD. But if
Because she is also giving lactation to her kids.
Dr. Ashish David Bad, WhatsApp
then we
audio.
only go for progestin only pills.
Okay.
Estrogen containing pills are contraindicated in the lactation.
Okay, madam. So we have to give her POPs. Now there is a rapid fire. We have got 5-6 minutes only because we have to finish at 7 o'clock. Okay, madam.
Yes,
So
sir.
everybody, Dr. Monica. Monica is there. Right? Monica, madam, what are the choices of pregnancy with jaundice?
So contraception, we are not supposed to give estrogen preparation to her because they are going to affect the liver. Whatever drugs are hepatotoxic should not be given. Better to go for a LNG IUS or a copper IUS or the barrier methods.
So all the progesterone is safe if the patient is jaundice because progesterone is estrogen we shouldn't give. Jaju madam.
So next is epilepsy, and I think Jalaksha or Prema Nagar, madam, if they are there.
We should advise for the IUD devices, non-hormonal, maybe hormonal. Progestin only pills can also be given in this kind of patients. These are the three, or barrier contraceptives if they strictly adulterate.
But in all these conditions, we must see that all the epilepsy should be controlled very well. MTP
Yes.
is not an emergency. We have to see that what are the anti-epileptic drugs they are taking,
Medicines taken,
and misoprostol and
yes.
mifepristone
Which
do not
medicines are
significantly interfere
And
with
the
the
drug
anti.
interactions of the drugs.
Yes.
Yes, yes. Dr. Prema madam.
Yes, sir.
Yes. Patient with SLE, immunological disease.
So non-hormonal IUDs are the better option for them. But they can take progestin only pills also. Oh, that is a very safe option for them.
Patient with antiphospholipid antibody syndrome, increased risk of thromboembolism. So POP or IUD is best.
The best.
Chaju madam.
In case of GI diseases, such as inflammatory bowel disease, what type of contraception is indicated?
So, when we talk about MTPs, so in case of GI, MTPs, medical abortion, it is safe until unless there is no absorption problem. Surgical is absolutely safe. When we go for contraception, then copper-Ts and progestin only methods are the best. It can go for implants, injections, and pills. Combination pills should not be given because there are chances of malabsorption.
Thank you, madam. What about the gynecological disease like patient has got some infection or patient has got endometriosis and she become pregnant. Now she doesn't want pregnancy. Which is your advice? That will correct both.
LNG IUD not in active infection.
For infections, sir, barrier methods.
Their method and POPs are better.
Yes.
So hormonal preparations can also be given. They are also going to help in the endometriosis.
Yes, very good because
In
that
case
is
there is
the
no running infection, sir. In case there is a running infection, then no copper-T, no LNGs. If there are no running infection, then LNGs can be given because they will help in endometrial reduction in endometrial growth also.
madam, nowadays people are using Dynogest. This also give you very good amenorrhea because patient has got symptoms of endometriosis that also cover. And
Covers in pills.
and if she wants to become pregnant, then now dydrogesterone is also good option. We can give dydrogesterone 30 milligram available in market. That will not hamper the ovulation. And if she become pregnant again, then it will nurture the pregnancy. because this might be the pregnancy sometimes unwanted, and when she want pregnancy we can give the option of Dynogest and Dydrogesterone both. Jaju madam.
In case of HIV, Dr. Prajakta, what would be the contraception that would be advised?
I think my
Anyone who wants to take Dr. Pradnya, madam?
We can use the non-hormonal methods like Papa IUDs are suitable. LNG IUS is again safe and effective, and we can use only POP methods are of choice. And we should avoid CSCs because if the patient is on antiretrovirals, it may give rise to drug infection.
Yeah, if husband is
You
taking
can go for a variant methods also.
barrier methods are, along with that we can use barrier method.
Barrier methods, so anyway, we have to use it because when we are talking about HIV, yeah, irrespective of what other method she's
Combined.
using,
Madam, he has not used barrier method, that's why he become pregnant, she become pregnant. So we have to must counsel her that if you want to prevent yourself from getting HIV infection, start using barrier method. Why you have to go for MTP?
Exactly.
So if so many times we see that what is the contraception failure, why she become pregnant. So one of the most important thing is non-use of contraception. Contraception failed to use make her pregnant, or this is the only entertainment they have and they are utilizing it fully, so that's why they become pregnant. Okay, so we have to counsel them that we have to do this type of things, use barrier method, and if he is not agreeing, then we can use IUD and LNGs. Jaju madam, cancer. Who would like to take?
Who would like to take that question?
Yes, no, sir.
Prajakta, madam?
Yes, unless we are very much sure that her serum beta HCG levels are normal, we should not advise her any contraception.
Post MTP, she has got 10,000 beta HCG.
Then we should not give her any hormonal contraception.
Okay.
We can go for IUD. We usually IUCD. We should wait actually till all the levels come down.
Because uterus is very fragile, very soft uterus.
Yes.
So the variant methods can go.
And if she wants to become pregnant again, then
And it has to be come down. The levels has to come down, and then
beta HCG should be at the normal level for at least 3 months. Then we can advise her to become pregnant again. Otherwise, there are so many chances. And then we have to see X-ray lung also for cannonball. We also see for thecal uterine cyst. Okay?
Yes.
But if she's not got anything and then there is still endometrial hyperplasia, then we can advise her LNG IUS. It will act in both ways. It will also decrease the endometrial thickness and it will also act as a contraception.
Yes, madam. Fantastic. So thank you very much, all my 10 women batsmen or batswomen, for giving me opportunity, because men need is difficulty because they are necessary to enjoy the success. So I am the only male in between the 10 and 11 beautiful women on this.
You have played very well. You have made everyone knockout.
very high actually.
So otherwise this is very boring topic of contraception and MTP, but we try to make it very useful, and I must thank so many pharma companies who are making dydrogesterone GIB of my paper. Out of 114 paper I had published. So at the end everybody should be happy.
Actually, the time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy
And have a little heaven right here. Thank you very much for